the babies with big head, it affect the normal labor process. Now the fetal lie, you can see in the picture, there are so many fetal lie. This is the first one is the longitudinal lie, and the second one is oblique. It is also longitudinal, sorry, and this one is oblique lie and transverse lie. Now the fetal position, these are the normal position, and these are the posterior position, anterior position, and two lateral position, and three anterior position, and three posterior position. This is the ROP is the 7%, right occipito posterior, OP is occipito posterior, that is very rare one, and left occipito posterior 3%. LOT is the most common one, and the mechanism of labor also I have shown of LOT. Left occipito transverse, right occipito transverse, right occipito anterior 10%, occipito anterior, when the occiput is facing towards the symphysis pubis, that is occipito. The definition I can repeat definition. LO is left occipito anterior, this is 13%. Now the different types of attitude, the universal attitude is universal attitude, flexion, deflection. Here you can see the diameter is shown here. When the baby is fully flexed, universal attitude, that is flexion, the baby's head engaging diameter is see, you can see by occipito pragmatic occipitogrammatic diameter. This is the when the baby deflects at occipitofrontal diameter 11.5 centimeter, and the baby is slightly extended. This the diameter is vertical diameter. And the baby's face is the presenting part here. It is presentation. Its presentation. Here the diameter is suboccipito. Submento-grammatic diameter 9.5 centimeter. Submento and suboccipitogrammatic, the both are same. Here the difficulty is here. Submento vertical diameter is the move, so it is difficult to deliver the baby normally. Here the flex attitude, one example. Now passage. The conic pelvis provides the basic framework of the birth canal. Gastric pelvis is divided into false and true pelvis by the pelvic being linear. The true pelvis is important for it. It is through the conference space that the fetus must pass on its journey through the birth canal. The type of female pelvis are gynecoid is the most common one. Broad inlet is there, and anthropoid and reticular, and small pelvic outlet can result in cephalopelvic disproportion. The body pelvis can be measured by pelvimetry, but it is not accurate as has been replaced by the clinical trial of labor. There are so many ways are there we can access the pelvis. Now these are the different pelvis and different diameter, and this is the division. Now let's start the physiology of first stage of labor. In first stage of labor, the first criteria is pain. The mother feels pain to move anterior with hardening of the uterus. Initial pain comes at the interval of 15 to 30 minutes and lasts about 30 seconds. In the late full stage of labor, the contraction comes at the interval of 3 to 5 minutes and lasts for 45 seconds. And the second feature is dilatation of cervix. Dilatation of cervix is related with the dilatation of external walls, and dilatation is expressed in terms of 1 to 3 finger or fully dilated. We can see one cervical diameter is 10 centimeter. You can see it's fully dilated. Inflammatory effacement proceeds the dilatation of cervix. So that is in multi-para, both occur simultaneously. In case inflammatory dilatation is 1 centimeter per hour, in multi-para 1.5 centimeter. per hour. Instead of the cervix is processed by which muscular fibers the cervix is moved upward and marches to the lower segment. This is determined by the length of the cervical canal in the vagina. And if the cervix, we can say the features are soft and 90% effaced, and that means one finger is easy and the cervical canals are delicate. So features of stage level is that is the feed between the two level and one and one side validation comes to 4 centimeter. In fact, it is about 10 or level it takes about 14 or everything. But active phase is the phase starts from the special validation and full centimeter more service dilates at least 1 centimeter per hour in this hour. This is the picture I have shown. This is in case of primary. The upper row is for the primary and the second row is for the molecular. Chemical factors responsible for the thyroid dilatation, polarity of the uterus, fetal axis membrane. These are the factors which helps in cervical dilatation. This is a simplified cartograph. It was introduced in hospital in 2000 by WHO. This is a simple way, this simplified cartograph is not shown by WHO. You can see so many components, fecal heart rate, and cervical dilatation, progress of member contraction, and you can see the graphs and maternal condition also is added here, pulse and beat and temperature. The restriction is there in the mentioned first stage of labor. The physiology of second stage of labor, uterine contraction comes at the interval of 2 to 3 minutes and lasts for about 1 to 1.5 minutes. Bearing down efforts, expansive force of uterine contraction is added by voluntary contraction of the abdominal muscle is called bearing down efforts. When the contraction comes and cervix is fully dilated, the woman is instructed to exert the tongue of uterus as done during streaming of stool. Membrane status, membrane is maybe ruptured with a gush of lacquer or vagina, and spontaneous rupture may not take place at all, allowing the baby to be born 1 minute on. See, here one picture is shown the station of head in relation to the shear spines. Descent of the head, the feature of descent of the fetus are evident from the abdominal and vaginal examination. Internal examination reveals the descent of the head in relation to the ischial spine. Abdominal assessment of the progressive descent of the head may be done by placing radial margin of the index finger above the symphysis pubis until the groove of the neck is present. So vaginal side also you can see as the head distance from the perineum, scalp head is visible. Rounding 6 place usually the head is borne down shoulder and the baby body follows with the next contraction accompanied by gush of amniotic fluid and sometimes blood. Maternal side of exertion, slow respiration and increased perspiration during bearing down efforts, the face becomes congested and following exhaustion of the fetus, mother shows sense of relief. This is the mechanism of labor for LOP. Engaging diameter, the transfer diameter of the inlet that is a 13 centimeter. Engaging diameter of the head is occipito-pragmatic 9.5 centimeter or suboccipito-frontal 10 centimeter. The first cardinal movement is engagement, increasing flexion, internal rotation of the occiput anteriorly to its circle of the pelvis, simultaneous rotation of the shoulder to one its circle of the pelvis. Next, grounding takes place and the delivery of the head by extension, distribution, external rotation and delivery of the shoulder and shrunk by lateral flexion. Physiology of third stage of labor. Third stage of labor comprises the separation of membrane and placenta and expulsion of both. The signs of separation: parenchyma, uterus becomes globular, firm and palatable. The fundal height is slightly raised. Parvaginum, side gush of vaginal bleeding, permanent lengthening of the cord is established. And maternal there may be chill and occasional shivering, and slight transient hypotension is not unusual. The management of labor general condition, you have to see is maximal observation with minimal active intervention. Preliminaries are cleaning, sterile gloves of pair, apron, sterile swab in Dettol or Savlon solution, 0.5% chlorine solution for decontamination, vulval cleaning, gloved middle index finger is used, and complete examination is done before the fingers are withdrawn from the vagina, and vaginal examination should be kept minimum to avoid risks of infection. So PV examination we can do the generally done at the interval of 4 hours. Degree of cervical dilatation in centimeter, degree of effacement of cervix. We have to see status of membrane, if ruptured, color of liquor, presenting part and its position, fontanelle is recognized both the posterior and anterior, caput or molding of the head, station of head, assessment of the pelvis in case of primigravide is done. Now the indications of PV examination: at the onset of labor, progress of to check the progress of labor following rupture of membrane, to diagnose the precisely the beginning of second stage of labor. Now management of first stage of labor, principles are non-interference with watchful expectancy, and to prepare the patient for natural birth, to monitor carefully the progress of labor and maternal condition and fetal behavior. Actual management and antiseptic dressing with a 10% Dettol, encouragement and emotional support and assurance is given to the mother. Position: comfortable position is preferable. Avoid dorsal supine position, and bowel soup and water or glycerin enema can be given. Rest and ambulation: if membrane is intact, the patient is mother is allowed to work, and ambulation reduces the duration of labor. Diet: liquid form diet may be given. Bladder care: catheterization is done with strict aseptic technique. Relief of pain, analgesia can be given. And assessment of progress of labor with and partograph recording: when the cervix is 4 centimeter or more, begin to plot the findings on the partograph. Maternal sign: pulse in every 30 minutes marked as dot. Blood pressure recording in every 1 hour marked using the vertical arrow, and temperature is recorded at every 2 hours and record in degree centigrade. Uterine contraction in every 30 minutes, and contraction is checked for 10 minutes, and duration of each contraction in seconds are recorded on the partograph in this manner. So weak contraction, if it is less than 20 seconds last, and marks as dot. Moderate 20 to 40 second, and crosshatch are marked, and strong strong contraction, that is more than 45 seconds or 40 seconds, the rectangular the means the uterine contraction area is darkened. To note the fetal well-being, FHR with rhythm intensity is noted in every 30 minutes in first stage of labor, recorded as dot on the partograph. In every 15 seconds, the second stage for 60 seconds, and following rupture of membrane. Note the evidence of fetal distress, that is FHR more than 160 beats per minute, less than 120 beats per minute, fetal heart rate irregularity, presence of meconium in amniotic fluid are noted. PV examination is done in every 4 hourly. The following parameters are checked: dilatation of cervix in centimeter, plot by placing X, and presenting part, status of membrane, and station of head is also checked. Status of amniotic membrane: ruptured, color of liquor, plot as follows: membrane intact, mark I, and membrane ruptured, plot R; clear fluid, plot C; and meconium stain liquor, mark M. And if it is the blood stain, Mark B. Degree of molding of head and caput formation are also checked. Urine output is recorded for volume, protein, and acetone. And any drug, oxytocin, and other is also recorded. Evidence of maternal distress. The signs are anxious look with sunken eyes, pulse rate more than 100 beats per minute, dehydration, dry tongue, offensive discharge per vagina, scanty color urine with presence of acetone. So management of second stage of labor principle is to assist the natural expulsion of baby to prevent perineal injuries. Preparation dorsal position with 15-degree lateral tilt and stand right side of the table, toileting the external genitalia, inner side of the thigh with Savlon Dettol or Dettol solution, catheterize the bladder, and conduction of delivery. The first one is delivery of the head. Maximum flexion of the head to prevent early extension and to regulate its slow escape of a bulbal outlet. Patient is encouraged for bearing down effort during uterine contraction. This facilitates the descent of the head. Episiotomy is given when the perineum bulges out and 4 to 5 centimeter scalp is visible. Slow delivery of head in between contraction is to be regulated. The mucus and blood in mouth and pharynx are to be wiped with sterile gauze, and eyelids are also wiped with sterile swabs. The neck is palpated for cord. Now, prevention, how can we prevent the perineal laceration? Delivery by early extension is to be avoided. They to deliver the head in between the contraction, to perform timely episiotomy, to take care of the delivery of the shoulder. Delivery of shoulder, wait for movement of the restitution and external rotation to occur. During contraction, anterior shoulder is borne followed by posterior shoulder by drawing the head in upward direction. Delivery of the trunk, after the delivery of shoulder, the forefinger of each hand is inserted under the axilla and the trunk is delivered gently by lateral flexion. Note down the time of delivery and place the baby on the mother's abdomen. Put identification mark, dry the baby, check for any abnormality. When the cord pulsation stops after 1 to 3 minutes, clamp and cut the cord 2 to 5 centimeter away from the baby's abdomen. Leave the baby on the between the mother's breast to start skin to skin care and breastfeeding. Now, management of third stage of labor. Before starting to manage the third stage of labor, rule out the presence of another baby by palpating the abdomen and trying to feel for fetal parts. Administer 10 international unit of oxytocin as an IM injection to the mother if she is in health facility, or give misoprostol tablets 60 microgram orally if it is home delivery. Now this is the you can see the diagram. There are two types of management: expected management of third stage of labor and active management of third stage of labor. I'll explain the active management of third stage of labor. Injection oxytocin 10 units IM preferred, or injection methergine 0.2 milligram IM to the mother. Nowadays the oxytocin is preferred to the mother within a minute of delivery or baby. Clamp and divide and ligate the cord. To deliver the placenta by control cord traction soon after the delivery of the baby, availing the first uterine contraction. If it fails, repeat after 2 to 3 minutes. Again, if it fails, wait for 10 minutes, repeat the procedure. If it fails, then manual removal of the placenta is done. First injection, oxytocin 5 to 10 international units, slowly IV or IM is given. Then examine the placenta and membrane for completeness. Inspect the vulva, vagina, perineum for any injury. Now this is the picture for control cord traction. You can see the fundal pressure is being given in rotatory movement, upward and downward manner. Here also you can see the cord is taken out. Now last slide is place the after the delivery. Place the instrument used in delivery in 0.5% chlorine solution for 10 minutes for decontamination. Very important aspect: decontaminate or dispose the syringe and needle. Immerse both your hands in 0.5% chlorine solution. Remove the gloves and place it in leak-proof container or plastic bag. Wash your hands thoroughly with soap and water. Clean, dry clothes or air dry. Management of fourth stage of labor: it is the observation at least 1 hour after the delivery of the baby, placenta and membrane, to ensure the mother and baby are well. Pulse and blood pressure and tone of the uterus well contracted or not, you have to see, and any abnormal vaginal bleeding are to be watched at least 1 hour after delivery. Examine the perineum, lower vagina and valve for tear. Monitor following in every 15 minutes general condition, BP, pulse, vaginal bleeding and uterus to make sure that it is well contracted. When the mother's general condition is good, pulse and blood pressure is steady, the uterus is well contracted, there is no abnormal vaginal bleeding, patient is sent to the ward. Thank you.
Thank you, Gauri, for your elaborate discussion regarding the care of mother during normal labor. You have well explained and gone through details in these topics, and I hope those who are presented in this webinar, you have learned that supporting mother during labor and childbirth is very much essential, and maintaining partograph, it is very important for the assessing the labor and as well as for assessing the mother's condition as well as the fetal condition. Maintaining privacy, and we should have the confidentiality and we should have the depth of knowledge and maintain the hygiene during the labor period is very much important. As a healthcare provider, we should maintain the documentation so that we can be assess the mothers during the labor. Thank you, Gauri, once again, and I hope that you have covered all the parts of the topics. Next speaker, we have the topics postnatal care, and this topic will be covered by Mrs. Monomala Das. She has completed her Masters of Science in Nursing, specialty midwifery nursing. She has done her Masters from Tripura College of Nursing in 2016, and she have the both clinical and teaching experience more than 18 years. I welcome Monomala to be present your topics in this webinar.
A very good day to all of you. Thank you, Madam Devi Chakraborty, for giving me this opportunity, and thank you, Madam Principal Madam, for giving this opportunity to speak about the postnatal care in this webinar. So, welcome to webinar conducted by Nursing Training Institute, and this session is for postnatal care. So, in the postnatal care, what will take the care for the mother? This thing we have to summarize first. What care we should take for the mother after the delivery, after the expulsion of the placenta, and the fourth stage also we are giving in the labor room, and then after then we will take the care of the mother. So in this regard, introduction of the postpartum care, then physical and psychological postpartum care, expected outcome for postpartum care, physiological need during postpartum, then cultural aspect and belief about postpartum care, discharge teaching, then follow up after discharge. So, in the introduction of this postpartum care, I can say these things. The goal of midwifery care in the immediate postpartum period is to assess women and their parents during their initial transition to parenting. So, we can say the how they will accept this mother and the baby. when a new person came in our family, we are happy and we used to take this baby. But some time we have seen in our clinical, in our experience, so some problem used to arise in that critical situation. A nurse only is the person who can take care for this family, for these parents to accept and to bring and brought up the baby in their family. So there is the midwives provided care that focus on the woman physiological recovery. Midwives, she will take care on the focus on the woman, means that is postnatal mother physiological recovery and psychological well-being, her ability to care for herself and her newborn. So in these things, a nurse can, a care provider can help the mother, her ability to care for herself and her newborn. And psychological support also, as we are nurse, we used to help the mother in this regard. Next, the stages of postpartum. Postnatal care is, if I define postpartum period, then it will be the from the delivery of the placenta, it can take, or from the 1 hour of delivery, placenta delivery, after the 1 hour of placenta delivery and up to the 45 days, we take it post natal period. So in this postnatal period, we are divided into 3 stages. This stage is immediate within 24 hours. After the delivery of the placenta, within 24 hours, it is with immediate postnatal period. Then early postnatal period, it is up to 7 days, and remote up to 6 weeks. Then the objectives of postpartum assessment. What are the objectives of postpartum assessment? Why we should take care for the mother? We have some object. We have to give the care for that only. This is the to prevent complication of the postnatal period, to provide care for the rapid restoration of the mother to optimum health, to check adequacy of the breastfeeding, to provide family planning services, to provide basic health education to mother and family. Postpartum physical assessment. After the delivery of the mother, we have to go through the postnatal physical assessment. In this regard, vital sign, we know vital sign is the sign which is provide all the information for the mother general condition. Then evaluation of the breast, whether there is any problem, any crack, nipple or anything is there, or milk is secreting or not, whether there is colostrum is present or not. These things we have to evaluate. Uterine fundus is involution is taking occur or not. This thing we have to take. Lochia, this is amount, color and odor. We have to assess the lochia. Then perineum area. Perineum area also there is edema or bleeding is there, or any infectional sign is there or not, we have to assess. Then bladder and bowel function, energy level of the mother, appetite of the mother. These are the graphical chart which is we should maintain in our clinical area, but in the practical field, we may not see this thing is maintaining in some state or somewhere, but only the student nurses, they used to maintain this chart. This is like a temperature chart. This is the vital sign of postnatal mother, which is give at a glance all the information. When we should when we maintain this graphical chart, then we can see the, by this paper only we can understand the mother, whether her everything is going well or not. See, here is the day of the perineum, perpedium, sorry, day of the perpedium, and the temperature and pulse. So this is the uterine involution. whether involution is taking properly or not. This graph, see, this is the normal graph. It is taking normally, and then this is the temperature also is normal. So if we will maintain this chart in the clinical area, then all healthcare provider, doctors, sisters, and others also can we can evaluate the mothers whether her postpartum period is going well or not. So this is important here. The lochia also we can. This is R means robra. This 4 days there is robra. Then 4 days 6 serosa, then alba. This we know as this all the nursing personnel we know that what is robra, serosa, and alba. So in this, if we maintain this chart in the clinical practical area, then we can give the proper we can assess the properly the postnatal mother. Then sign of potential complication. If we maintain, if we assess properly the mother, then only we can find out. We can find out the sign, that is potential complication. What is the temperature? In this previous slide, I have shown the graph. If there is temperature is not normally going, then there may be some chance of infection or chance of some deviation from the normal things. So temperature more than 38 degree of centigrade, 38 degree centigrade after the first 24 hours. This is 38 degrees centigrade after we know the normal pulse temperature is 37 degrees centigrade. Then after first 24 hours, if it is more than that, then there may be some sign of complication. Pulse, there may if there is present tachycardia or marked bradycardia, then there is the sign of complication. Blood pressure, it should not be hypotension, it should not be hypertension. Energy level, lethargy, extreme fatigue, uterus deviated from the midline, boggy consistency, remain above the umbilicus after 24 hours. This is the sign of complication. Lochia, heavy foul odor, bright red bleeding, that is not lochia. So we have to keep in mind that lochia, what is lochia and the difference lochia and bleeding. So if there is heavy foul odor, then bright red bleeding, that is not lochia. Then perineum, pronounced edema. If there is edema, not intake sign of infection, marked discomfort, then there may be complication. Breast tenderness, heat, contracted nipple, then inverted nipple, palpable mass should not be present. Elimination, urine inability to void, urgency frequency, dysuria, it is not normal. Bowel constipation or diarrhea, there may be some a little sign may arise, but if it is vigorous, it is not normal condition. Then expected outcome. Then expected outcome of care. Then demonstrate normal involution and local characteristics. Remain free from infection. Demonstrate normal bladder and bowel elimination pattern. So if we take this assessment and we assess the mother, postnatal mother, then what will be our outcome? What we can find? This is the things we can understand the level of the fundus after delivery. That is, just after delivery, immediately it is set above the umbilicus level, and with 24 hours it is the level of the umbilicus, and then gradually it is decreased. This thing every day, if we assess, then we can find out whether there is any deviation from the normal, there it is decreasing or not, or there is any sub-involution is occurring. That's things we can find out only if we assess the patient clinically. In our clinical field, all the nurses, all the care provider, we should assess properly the postnatal mother. Then physical care during postpartum period. What physical care mother needed in the postnatal period? That is physiological care, prevention of infection by applying hand washing technique to prevent cross infection. That is the most important hand washing technique. WHO has provided the 6 steps of hand washing technique. This is very simple and very easy, but it is very sorry to say we are not maintaining properly. Those we are present in the clinical field, we are due to some unavoidable situation, we are not maintaining. So this is the most important part to prevent cross infection by proper hand washing. So I'm showing the only simply I'm showing the 6 steps of hand washing. This is we have to remove all the jewelries, watches, and finger rings or anything. We have to wash, and then we have to get our hand and take the soap or hand wash, and then these 6 steps we have to enjoy with this hand washing procedure. Just vigorously have to take the soap, and like this we can pump to pump 1 2 3 4 5 6 7 8 9 10 1 2 3 4 5 6 9 10 like this. First step, pump to back, then ankles like this, and then palm and creases, fingertips and creases, and then thumb, both hand, thumb, and then the wrist. This is the simple 6 steps. We can enjoy this hand washing, and we can prevent the infection, that is cross infection, which is we are giving to the patient or from the patient we are taking. These things we can maintain by proper hand washing technique. So maintenance of clean environment. For the postnatal mother, we have to maintain clean environment, bed linen, then surroundings, all things we should maintain properly. Bed linen should be changes as needed. Whenever is needed, bed linen should be changes. Disposable pad should be changed frequently. There is no proper time that 1 hour, 2 hour we have to change, but when it is become wet, then we have to change it. Otherwise, if there is no heavy bleeding, 4 hours we can change the pad. Then proper supervision. All the healthcare providers should keep the supervision for the postnatal mother. Episiotomy laceration care. Proper hand washing also there is important. Washing perineum, clean from perineum to anal canal. This is the most important thing. Should clean the perineum, from the perineum to the anal canal. Applied peri pad from front to back. That is peri pad. That is perineal pad from the front to back. Change pad with each boy, then 4 times a day. Then episiotomy also. These things, the episiotomy care nowadays, the ambulatory patient, they can do themselves, or those patients are bad after seizure, we can take care. Otherwise, mother can take. We have to teach the mother only how to take their episiotomy care. Then prevention of excessive bleeding. This is the most important after the postnatal, during the postnatal period. Cause may be uterine atony. Then accurate visual estimation of blood loss is an important nursing responsibility. That is the scanty, and that is the light, moderate, and heavy bleedings. Then loss of blood usually described subjectively. That is, I have said already. Less than 2.5 centimeter. This is scant. Light, that is equal 10 centimeter. Moderate, more than 10 centimeter. Heavy, that is 1 pad situated within 24 hours, or it may be within 2 hours, 1 hour also. Evidence. There is the one evidence that is the estimation of blood more accurate than visual estimation of detection of postpartum hemorrhage. This evidence is taken that the our estimation is by visual is not accurate. It is the pad estimation is so these things should keep under observation whether there is postpartum hemorrhage or not. Maintaining good uterine tone, prevent bladder distension. This is how can maintain uterine tone. The intermittent uterine masses can prevent. There is one evidence to maintain. Prevention of bladder distension. Full bladder cause the uterus to be displaced above the umbilicus and well to one side of the midline in the abdomen. Also prevent the uterus from contracting normally. So uterus should not be full. See this in this picture. This is the bladder. If bladder is full, then uterus will be tilt one side, not in the midline. It should be in the midline of the umbilicus. It is not in the midline. So these things we have to empty the bladder. Physiological need. That is the comfort after birth pain, episiotomy, perineal laceration, hemorrhoid, breast engorgement. Then for episiotomy care we should take, encouraging the woman to lie on her side, use pillow when sitting, use ice pack in the perineal area if there is pain, to rest, sleep, as mother is tired during the labor. So excitement and acceleration after birth, long labor, infant behavior and demand breastfeeding. Breastfeeding also is important for postnatal period. We have to assess the baby also and give the best feeding also for the baby. So no soap on the nipple, wash in water, wear supportive bra, breastfeeding tips. Most important is the latch on, then teach mother to assist with the infant getting the nipple and areola in the mother. I think this breastfeeding in the next newborn assessment, there will be some tips or maybe. So anything, simple physiology of lactation. This is the simple physiology. All of us, we know how the lactation is take place. This is the when the baby touch the nipple, then the nerve impulses go to the hypothalamus, and hypothalamus stimulate to the pituitary gland. Then from the pituitary, that is oxytocin is releasing, and then this is the simple physiology of what is this lactation. Then lactating mother. A healthy mother will produce about 500 to 800 ml of milk a day to feed her infant with about 500 kilocalorie per day. This requires 600 kilocalorie per day for the mother, which must be made up from the mother diet or from her baby. So this is the breastfeeding technique. This is figure A for four common breastfeeding technique. This is football holding, and this is lying down, and this is cradle, and this is across the leg. These are the four feeding technique. We should follow. We should teach the mother during postnatal period how to feed their baby. So ambulation is most important. Early ambulation, nurse should be considered the baseline of blood pressure, amount of blood loss, timing, then analgesic when assisting women to ambulate. If there is pain, episiotomy or cesarean section, then painkiller should give according to physician, I mean gynecologist opinion. Then postpartum or postnatal exercise is the most important. All the postnatal mother should teach about the postnatal exercise. After it should started from the light exercise to the vigorous exercise. These are the some pictures are there for postnatal exercise. This is the we know everything about this exercise. Even though I am showing here, this is deep breathing, then pelvic tilting, then some exercises there. We should teach all these exercise to the postnatal mother. And one important is evidence are there. Exercise is in the postpartum period is shown the produce of more relaxed mother-child relationship, combat depression, and improve perception of the new relationship. Exercise help new mother sleep better and have less anxiety. So this is most important for exercise for the postnatal mother. Not only for this, there is contraction, then muscle tone also, then maintaining posture also is important for the postnatal mother for exercise. This is nutrition. Most women display a good appetite and eat well. Nutritious snacks are usually welcome. Cultural dietary performance must be respected. Prenatal vitamin and iron supplement as should be continue up to 6 weeks as according to the mother condition. Psychosocial assessment during the postpartum impact the birth experience by the inviting the partners to review the event and describe how they feel, help to nurse to assess how they understand what happened and how well they have been able to put their child birth experience into perspective. These things we have to understand. Impact of the cultural diversity also. Nurses are likely to come in contact with the women from different countries with different culture. So we have to respect their culture must. Then the parents-infant interaction. Assess the mother and father reaction to and interaction with the new baby. Positive parent-infant interaction include taking pleasure in their infant, in tasks done for and in him or her, understand their infant emotional state, and providing comfort. Family structure and functioning. Nurses can help to the new mother return to home by identifying possible conflict among family members, helping the woman plan strategy for dealing with those problems before discharge. Discharge also, there should be pre-planned. During the admission, mother will discharge only, reflect in the plan for care developed of each individual woman by teaching for self-care, sign of complication, basic instruction regarding resumption of intercourse, and then prescribe medication. Then the advice, what advice will give the postnatal mother during discharge? Rest, avoidance of weightlifting, advice to consume nutritional diet, then breastfeeding, care of newborn, abstinence of coitus for 2 to 3 weeks, postnatal exercise, contraception should be used if sexual activity is resumed, postnatal follow-up up to 6 weeks. In case of lactating mother, iron, calcium, and protein supplementation is continued till lactation. Tablet, also iron tablet may give for the mother. Then anti-inflammatory analgesic should take, antibiotic should give, then local perineal care, mother should take perineal care. After boarding, should use washing the perineal care. Follow up after discharge. Mother should give discharge, and we should track the mothers after discharge also. Those are the NM or ASHA worker also, they used to visit, NM also used to visit. All the health worker should keep in mind that after discharge also, mother should be, by maintaining protocol, should visit. Home visit to new mother and babies, few days of discharge can help bridge the gap between hospital care and routine visit to healthcare providers. Then the summarization. Postpartum is the modeled in the concept of health. Postpartum care is the model for the concept of health because if we take the proper care of the mother, assist the mother, give the nursing care to the mother, keep the on supervision